My name is Jennifer Grauska from the University of North Carolina at Chapel Hill. Welcome the few, the proud that made it to the end. Thank you for staying. Pleased to welcome you to our seminar today, Advances in Imaging. I have no relationships to disclose that are related to this brief presentation that I'm giving, and neither does my co-chair, Dr. Narkowitz. So the old adage states that a picture is worth 1,000 words. From the earliest description of CF to the devastating effects of the disease, these images confound our senses in a way that words cannot. Clinicians use imaging studies in routine decision-making care and clinical care, as well as to identify novel methods and biomarkers to detect complications of CF. The symposium seeks to give a broad overview of the application of imaging technologies to identify disease and assess the treatment of bronchiectasis, sinusitis, liver disease, bone health, osteoporosis. We have an exciting lineup of speakers who will introduce concepts that are currently clinically available for disease identification and management, and then we'll touch on emerging modalities of interest. After the presentations, or we're going to do our questions at the end of the presentations, you can feel free to put them into the app as you've been doing all conference. We're also a small enough group that I'm pretty sure we can hear you, and we have a microphone that I'm happy to come out in the audience and pass it around if that's easier. We'll do questions for each speaker right after their presentation, but if there are any lingering questions for one of the earlier speakers, please feel free to ask them at the end as well. So first up, I'd like to invite Dr. Laura Walkup. She's a assistant professor in the Division of Pulmonary Medicine and Department of Radiology at Cincinnati Children's Hospital Medical Center. She earned her PhD in chemistry in 2013 from Southern Illinois University in Carbondale, where her dissertation focused on the production of hyperpolarized xenon-129 gas for magnetic resonance applications. She subsequently joined the Center for Pulmonary Imaging at CCHMC, where her research now focuses on all aspects of hyperpolarized gas MRI. She was the 2022 recipient of the Ann Woolcock Award from the ATS Assembly for Respiratory Structure, and her talk today is entitled Advances in Functional Pulmonary Imaging. I don't know how to get this out of mine there. There it is.
You're making me nervous about technical difficulty stuff. Thank you, everybody, for being here with us. Yeah.
And you can get a laser if you want to use pointer.
Oh, I thought
It
doesn't do that.
No, click on that.
Yeah.
The laser. Then
Perfect.
when you throw it up, they'll see it.
Thank you. I
And
love
if you
that.
click the first one, it'll work off the keys.
10-4. I appreciate that. Thanks, everybody, for being here in mile 26 of the marathon that is North American CF Conference. I need to disclose my relationship with Polarian Imaging. So the structural pathology and the progression of the structural pathology in CF lung disease is well characterized, or at least it was or is for pre-modulator era CF. So my task today is what's new with lung imaging in CF, with the big caveat that there's a lot of innovative imaging science that's happening beyond what I'll be able to talk about today in 20 minutes across many different modalities. So my educational objective here is to highlight some of the recent advancements in imaging technology, and I'm going to focus on two modalities in the interest of keeping our sanity. We've got chest X-ray computed tomography and a hyperpolarized xenon gas MRI. If you want to learn more about lung imaging, take a picture of this slide. These are good recent review articles about imaging lung disease and CF, and they'll help point you in the right direction and teach you what you need to know about structural proton imaging and fluorinated gas imaging, and these topics as well. We know that the structural lung disease in CF presents in very early life, and this recent paper from Brody et al. Aimed to look at the natural history and progression of CF lung disease in preschool age children. So they had 42 children with CF, ages 2 to 6, with baseline imaging and imaging at 18 months later. And they used a reader score to understand the progression of bronchiectasis, mucus plugging, and air trapping. And you can see here in these individual plots the trajectories for each of those structural aspects. And they reported that 64% of this cohort had at least one finding on their baseline scan, and that increased to 75% of the cohort at the 18-month follow-up. What they really emphasize here is that there was a wide range of individual trajectories. They showed here too also improvements in bronchiectasis, and that's demonstrated by this patient up here. You might be able to see it on this slide. Several very prominent bronchi appear to be more normal in size on that follow-up scan. They also emphasized that there were genotypic differences in this group, although the subgroup analysis got pretty small with individual genotypes. But the real take-home message from this paper was that there's a lot of different trajectories of structural change, even in very early CF lung disease. And so we should be thinking about trajectories on an individual later and thinking about how do we factor that into any sort of multi-site trial that might use imaging outcomes to assess treatment response. Moving away from reader scoring, you've probably heard about artificial intelligence or machine learning. It's a very buzzy word in radiology. And I think this paper from Gael Dorns, Chase Hall, and others is a really good example of what goes into developing a machine learning algorithm and testing it and validating it. So here, this was a multi-site retrospective study with 184 people with CF across the age of 4 to 54. They broke this data into a training set to help train the AI algorithm or what to look for, and a testing set. So between these two aspects of this machine learning algorithm, this was over 35,000 individual CT images that were labeled by radiologists for these structural aspects of CF lung disease. So after the algorithm was trained, they tested it, and this is 3 example patients from that testing cohort, and you can sort of visually appreciate the advancement of lung disease here. And then these were the AI-derived labels. So this is the machine learning algorithm picking up on the structural pathology. And then in these 3D reconstructions, you can sort of appreciate that the second patient has a lot of these distal mucus plugs. Those are all the little yellow speckles, compared to the person who has more advanced lung disease that's really dominated by all this red and airway lumen dilation, bronchiectasis. So they found very good agreement between the AI-derived volume of abnormal lung with the manual segmentation. And then they took this a step further, and they had a clinical validation cohort with 70 patients who had 2 CT scans. 10 of these patients had a baseline scan and a scan at 1 year post LUM-IFA initiation, and 60 patients had a baseline scan and a follow-up at 2 years without any therapy changes. And so perhaps, not surprisingly, the people who had no therapy changes saw an increase in bronchiectasis and an increase in periobronchial thickening that was picked up by this AI algorithm. And in the patients who were on lumacaftor, ivacaftor, saw a reduction in periobronchial thickening and a reduction in mucus plugs. And this is an example of one of those patients. So here we've got the baseline data, and in the right column we've got the 1 year follow-up. These arrows are pointing at little tiny mucus plugs in the distal lung, and you can see that better in the 3D reconstruction. And then at 1 year on therapy, you'll notice that those mucus plugs have been resolved. And it's tiny on the screen, but this person had no FEV1 change. So here we're using this AI algorithm to detect a treatment response that FEV1 was blind to. And there are lots of different AI papers out there, but I think this is a really good example of what it really takes to build and implement an AI algorithm to look at structural changes in CT data. So we looked at ivacaftor, lumacaftor. Let's have a look at ETI therapy. This paper by Beck et al. Looked at 12 adults with severe CF with baseline scans and then scans at 1 year after the initiation of ETI. And you can see that these folks had advanced lung disease when they started therapy. These are example images from 2 of those patients. And it might be hard to see, but there's white arrows here in patient 1 that are pointing out mucus plugs. And at 1 year on therapy, those mucus plugs have been resolved. In patient 2, the structure of the disease looks different. This white arrowhead is picking out peribronchial thickening, which resolves after 1 year on ETI. And if you look here, these bronchiectasis are circled. They don't resolve, but they don't worsen either on ETI therapy. So they saw an overall reduction in the reader score that was largely driven by reductions in mucus plugging and reductions in peribronchial thickening. Excuse me. And furthermore, what's neat about this, they correlated the degree of change on the CT scan to improvements in FEV1% predicted. So now we're seeing a structural change that's giving rise to a functional improvement on therapy. All right, that was the quick highlight of CT scanning and what we're doing, or CAT scanning. So this is the only joke I could find about CAT scans. Radiologists need to have a better sense of humor, I guess. So now we're gonna pivot, we're gonna talk about hyperpolarized xenon gas MRI. So a reminder for folks who don't know, xenon is a noble gas. It lives all the way over on the right-hand side of the periodic table, so it's chemically inert. And xenon-129 is a non-radioactive isotope of xenon gas that we can detect with the MRI scanner. Reminder, MRI has no ionizing radiation. And we hyperpolarize the gas so that we can detect it during a breath hold maneuver. So I want to spare you guys the fancy physics that I love, but we do fancy physics to make the gas hypermagnetic so we can see it in a breath hold. We run it down to the MRI scanner and we ask the patient to inhale and hold their breath. The xenon gas is dosed at about a tidal volume. So during that breath hold maneuver, we take pictures of where the gas goes. If you want to know more, take a picture of this slide for some good recent review articles on hyperpolarized xenon specifically. So the most simple technique we can do with this gas is look at lung ventilation. Where does it go? So in the absence of airflow obstruction, the xenon gas should go everywhere uniformly. And that's what we see in this healthy control child. These are axial slices that are taken in a plane, sort of parallel to the floor. And all the bright stuff is the xenon gas. And I've here added some anatomical landmarks to help us understand. So the hot spot there in the middle is the trachea. And then you can see the carina where we split into the right and left lungs. And as we go down through the slices, eventually we start to cut into the top of the diaphragm. So that's just partial voluming. That's not pathology. So what about airflow obstruction? Just like the plumbing in your house, the airflow obstruction prevents the gas from passing into the distal lung. So we start to see the emergence of ventilation heterogeneity and ventilation deficits. So in this 8-year-old child with CF, you don't have to be a radiologist to see the difference here. And now I've made copious use of white arrows to show you where those ventilation deficits are. And you'll notice that the lung picture has a lot of heterogeneity. So not all of the deficits are completely black, right? So that's telling us that some of that airflow obstruction is partial. So some of the gas is getting in, but not as much as the rest of the normally ventilating lung. CF is probably among the most characterized lung condition with hyperpolarized gas. This is by no means an exhaustive list of papers in hyperpolarized xenon and CF, but if you want to learn more, take a picture of this slide. And you can see these papers where we've demonstrated that xenon MRI is sensitive to early airflow obstruction in people with CF and normal FEV1. We've seen that the xenon gas is highly reproducible and sensitive to longitudinal changes. Matt Wilmering and his team looked at regional structure-function relationships. So if we have structural imaging and the functional imaging from the xenon gas, we can learn about what structural pathology is giving rise to those ventilation defects. It's feasible in multi-site trials, and here Marcus Couch did a retrospective study with data from a couple of different xenon sites and showed that those measurements were repeatable. And Jonathan Raymond showed a very nice paper with response to IV antibiotics post-pulmonary exacerbation. Again, not exhaustive, but just to give you the lay of the land. So now I want to introduce the High Point study. This is hyperpolarized imaging for new treatments. This is a CF Foundation funded study and the first prospective multi-site trial that's using xenon MRI as an outcome. So the goals of this study were to harmonize the xenon MRI acquisition and the analysis in a multi-site study. In phase 1 of the study, we were looking at same-day reproducibility of xenon MRI and stability over the short term, so here 28 days with no therapy changes. And in the second phase of High Point, we were looking at treatment response to ETI and the stability of those changes over time. And this is in young people ages 6 to 11. There are 4 study sites for this. This is all part of the Xenon MRI Clinical Trials Consortium. So Cincinnati Children's, the Hospital for Sick Children in Toronto, University of Virginia, and the University of Wisconsin-Madison were all participating in this study. So now I just want to give a few highlights from what we've learned so far of the study. This is an abstract I presented at this meeting last year where we saw that xenon MRI had high same-day reproducibility in this cohort. So again, these are young teenagers with CF and very mild lung disease. We were sensitive to ventilation defects as we expected. So the average ventilation defect percentage was somewhere around 8% for these kids. We asked them, after we took one set of images, to get up from the MRI scanner and walk around a bit and come back and see us again. And we saw that these ventilation deficits maintain their location and their size and their extent. We saw very good reproducibility in the measurement. And then this is a poster that I presented at this meeting, so if you didn't see me at my poster session, you're seeing it now. We looked at ventilation changes in response to ETI therapy. So we performed two xenon scans, one at baseline and then one after 30 days of clinical initiation of ETI. We saw an improvement in FEV1% predicted across the group, and you can see that in these individual trajectories. And we also saw a reduction, which is an improvement in the ventilation defect percentage. And if we plot the change in FEV1% predicted on the y-axis here, and the change in the VDP here on the x-axis, and I drew lines here at what the sort of median response was. So here's 6% FEV1 improvement and 2% VDP improvement. You'll see that 11 of these 19 children had a response with VDP, but only 9 children had a response that we measured on FEV1. And what's really interesting are these 3 dots down here. These are participants who had only a response that we detected with the xenon MRI and not with FEV1. And here's a pretty picture to show just improvement in ventilation, again, after only 30 days on therapy. There's other things we can do with the xenon gas besides ventilation imaging. So I want to introduce this concept of gas exchange MRI. During that breath hold maneuver, a small fraction of the xenon gas passes into the interstitial tissue and into the red blood cells. And if you remember your organic chemistry, for better or worse, this gives rise to a chemical shift, and this is an NMR spectrum. And each of these peaks corresponds to one of those 3 compartments in the gas exchange. And we image all 3 of these things simultaneously during the breath hold. So I want you to think about this as being a higher resolution diffusion capacity measurement. It's higher resolution because it's imaging, but it's also higher resolution because we can differentiate these 3 compartments. We can be quantitative about these measurements. These are example images from each of those 3 compartments. And we compare the signal intensity in that individual case to a signal intensity distribution that we have generated from a healthy reference cohort. So this is the same kind of way that we interpret pulmonary function tests, where we have a predictive equation that's based on lots of healthy reference data, and then we have Z-scores that tell us abnormalities outside of that. And so I want to focus on 3 outcomes from the xenon gas exchange we can use to look at CF lung disease. We can look at regions of the lung that have low ventilation. That's what we've been looking at together so far. We can look at xenon that's in the high membrane compartment. So this is more xenon gas in the interstitial tissue than what we were expecting. And we can look at the volume of lung with low RBC uptake. And so that's reflective of a diffusion deficit. And we did this as a pilot study in 40 people with CF. And what we found was that people with CF had airflow obstruction, of course, but we also saw this interesting high membrane uptake compartment in that compartment. So that's indicative to us that there's some kind of thickened alveolar capillary barrier that could be attributed to inflammation or fibrosis or maybe even mucus. We're still trying to figure out what that is. But no impact on the diffusion to the red blood cell. So as people with CF are living longer lives with subclinical or mild lung disease, it's really important that we think about the way that we're using imaging outcomes. So chest X-ray is clinically ubiquitous and provides high spatial resolution imaging. We saw response to therapies using chest CT scans, and AI algorithms might improve our sensitivity and objectivity compared to reader scoring systems. There are considerations. Low-dose CT protocols are becoming more popular. We have no, there may not even be a reason to do expiration view imaging if we're not interested in air trapping. You need a lot of data to train AI algorithms, and that diversity that we saw in that first paper with natural history and progression might need to be considered in designing multi-site trials. With xenon gas, we can look at lung ventilation and ventilation heterogeneity. We saw improvements with therapy, and we saw this weird gas exchange abnormality in CF that we're still trying to understand. There are some considerations here too, though. Cost, availability. Xenon is still regulated as an investigational agent, and so it's currently has limited availability. And there's technical expertise that's required to get these techniques up and running. So that just means that there's opportunities. We need more sensitive, repeatable tools to assess lung structure and function in this new era of CF. And so in order to do that, we need consensus guidelines. We need to be doing more to better understand the timing and frequency of imaging, risk stratification, who should be imaged more frequently or less frequently. And we need to work on harmonizing our acquisition protocols and the way that we analyze the data. We also need more prospective longitudinal multi-site trials to amass the amount of data required to answer these questions. And so to me, if we're gonna see clinical implementation of these lung imaging tools, these 2 things, the consensus guidelines and the trials, will work hand in hand to help answer those questions. And so with that, I wanna say thank you and safe travels.
Thanks, Laura. Couple questions. Jennifer has the microphone, so if you do want to ask a question, you can raise your hand. Jonathan Zuckerman asked he's asked 2 questions. Thank you, Jonathan. First is a technical one. Xenon MRI images, are they captured during inspiration or expiratory breath hold, or does that not matter? And how long for image acquisition?
Yeah, that's a great question. So they're captured during an inspiration of about a tidal volume of the xenon gas. And the second question was, it takes about 15 seconds to do the gas exchange imaging that I showed last. That's about as long as we do a breath hold for. For ventilation imaging, we can get images in 2 or 3 seconds, depending on the size of the person that we're imaging.
And then he's clearly thinking about his smaller center, and
Absolutely.
Are AI algorithms for chest CT imaging and CF available in the public domain or as commercial products? And if not, I'll add on to it, he didn't ask this, do you think they will be? And if the answer to that is yes, sort of timing.
No, that's a good question too. So there are commercially available chest CT algorithms. I'm not familiar with those as much. We do a lot of our own homegrown kind of things. My understanding is that many people who sort of grow their own algorithms will deposit that information on, say, GitHub or some other public repository to make those things more accessible. I think that as time goes on, you're going to have that kind of spread in your data to really train your algorithms well, because if all they're used to seeing are ducks, then they're never going to get used to like looking at geese or something else, right? So I think those tools will be widely available.
And then as a follow-up, Vanessa Diamond has asked, has there been any progress in AI algorithms for xenon MRI images?
Who wants to review a paper? No, I'm just kidding. We are working on those things. The ventilation heterogeneity, it always has bothered me that we collapse all of the cool spatial information and we make it one number, the VDP, so that we can compare it to FEV1. But in modern CF, that's not gonna cut it anymore. So having an AI algorithm that could pick up the heterogeneity, the shades of gray, I think is gonna have to be the way that we move forward.
Laura, I have a question.
Sure.
The interesting data regarding the higher membrane takes and suggesting the diffusion capacity issue. Is there any suggestion, have you had any data yet that shows this improves with ETI that parallels with ventilation improvements?
That's a really good question, and we don't have that data analyzed yet. But that is a good point. That ventilation improvements, we may also see sort of a resolution of the high membrane uptake, especially if we believe that it's coming from things like peribronchial thickening or mucus plugging that is now being resolved with ETI. So hopefully I'll have answers soon.
And then I'll ask the question I got here, and then Jennifer's coming over there. Joshua Galanter asked, is xenon MRI going to become more widely available, or is it just going to continue to be limited to the imaging consortium?
Xenon MRI will become more widely available. So the Polarian, the company that manufactures the polarizing devices, they've been seeking FDA approval, and that's anticipated sometime within the next year. And I think at that point, when there's not as many regulatory hurdles, I think larger academic centers will be interested and be buying those devices. I still don't think it's going to be something you're going to have at every small regional hospital, but I think it's going to become more widespread where more people can have access to that outcome.
Have you started, or has anyone that you work with started looking into the predictive capabilities of maybe not the fully defect areas, but the areas that are, at least like the algorithm we use, we call them cluster 2. I'm not sure if it's the same, but, and yeah, like predictive capabilities for pulmonary exacerbations, at least in CF and other stuff like that.
No, thank you. This is a really great question. And we have been looking at that. We don't have anything published as of yet, but one of my interests are, do the ventilation deficits that we see, how do they grow and change? Does a region that's kind of gray just become completely dark and completely obstructed, or do smaller little ventilation partial deficits, do they kind of merge together, and how does ventilation change over time? And is that indicative of a way a person's disease is progressing? Is it worse to have lots of little bitty defects or one big completely dark defect? So it's a really great question, and I don't have an answer for you yet.
No worries, thank you.
Thank you.
All right. In the interest of keeping it for everyone, we're going to move on to the next. Thank you very much.
Thank you.
I'd like to introduce our next speaker. It's Dr. Adam Kippel. Adam is an assistant professor in the Department of Otolaryngology and Head and Neck Surgery at University of North Carolina, Chapel Hill. He did his residency and fellowship in rhinology, allergy, and endoscopic skull-based surgery at UNC in 2018. His research, which is the reason he's here, is centered around identifying novel genes that regulate mucociliary clearance in the upper airway. He's had multiple awards and academic achievements, and clinically in research, he's the director of rhinology research at UNC. Adam?
Thank you very much for that, and that's a tough talk to follow with all that fancy radiology. So this talk's going to be a little more clinical, simple radiologist by a surgeon. I have no disclosures to make. So briefly as the outline for today, we're going to talk a little bit about sinuses, imaging modalities for sinuses, what a normal sinus CT scan looks like and kind of the key things to look for, and then characteristics of cystic fibrosis seen on a CT scan of the sinuses, and some considerations of when to get imaging. So the real reason we have sinuses is never going to be known, but kind of the things we purport are they're there to absorb shock. They're the fascia's crumple zone. So before your brain gets injured or your eyeballs get injured, the sinuses will crumple and kind of protect your eyeballs and your brain. They also serve a key point, especially in this crowd, of humidifying the air and warming it before it gets to the lungs for alveolar gas exchange. They protect the lower airways with a lot of large particles kind of precipitating out in the sinonasal cavity before it gets to the trachea and distal airways. Obviously, it's the home of olfaction. And then the other practical consideration is that sinus is really light in the skull. If your face was solid bone, it'd be very hard to walk upright. So one of the nice things about sinuses and sinus imaging is the structures are relatively simple. We have bone, we have mucosa, we have mucus, which looks about the same as the mucosa, and then we have air, which is generally going to be black on the scans. And so we don't have all the subtleties of the grays that we were looking at on the last images that kind of pulmonologists are used to looking at as they go through chest radiology. So modalities for sinus imaging, they're essentially threefold because ultrasound isn't really an option kind of given the air density. So you have X-ray, which is fairly cheap. It's about $133 for a sinus X-ray, and it's relatively obsolete. A lot of radiologists can't read it. Most clinicians can't. And the sensitivity and specificity are probably close to 60%, and so it's not the most useful of imaging modalities. If you're just looking at maxillary sinuses, which sometimes maybe you'll want to, which are the sinuses in the cheeks or below the eyes, the sensitivity raises up to about 80%, but in general, it's not optimal. MRI, or magnetic resonance imaging, is a really amazing modality for soft tissue. But as we kind of went through in that second slide, there's not a lot of soft tissue concerns in the sinuses. We're looking at air, bone, and mucus or mucosa. And so that doesn't actually buy us too much of an advantage. It's nice because there's no radiation. It can really help us distinguish dura from CSF space if we're concerned about kind of sinus things extending intracranially. But in general, that's not a big consideration in cystic fibrosis. There's actually a very high false positive rate for sinusitis with MRIs because depending on the nasal cycle, which is kind of the back and forth, left and right swelling that happens throughout the day, you can see lots of inflammation just kind of depending on the exact time you're capturing those imaging. And a small cold, which causes some edema in the nose itself, will dramatically show enhancement on the water signals on an MRI. It costs a significant amount. A cranial nerve 5 or kind of a sinus MRI can take up to 45 minutes. And then it's sensitive to motion, which is tricky with kids or claustrophobic adults. So we get to our CT scans, and these have become the gold standard in sinus radiology. There's great resolution between the air and the bone. They're kind of consider them a medium cost, depending on exactly where you're getting them and in your insurance carrier. In general, as an ENT or a rhinologist, we don't get these with contrast, and I'll explain that a little bit more on the next slide. And then the radiation dose, while it does have radiation, it's relatively low. A chest CT often has around 7 millisieverts. A sinus scan, depending on if it's a cone beam or a conventional or exactly how the protocol is, can be dramatically less than that 0.05 to 2 millisieverts. And as a comparison, I often tell my patients that about 10 hours on an airplane, a commercial airplane flight, is about the same radiation exposure as you get with a CT sinus scan at most centers these days. And it's very quick. Once you're actually kind of still and in the CT scanner, it probably takes less than 30 seconds. So the contrast thing. So contrast is very helpful for looking at soft tissue, but if we're only concerned about kind of sinus disease or sinus opacification, it's not particularly helpful. I use a contrasted sinus CT looking for abscesses. So if somebody comes in kind of with a facial cellulitis, their eyes swollen shut, or kind of have neurologic symptoms of meningitis, I think a contrasted CT is helpful, a contrasted sinus CT. We can use them for identifying localization of large blood vessels, specifically looking where the carotid artery is. Because as you'll see in a couple slides, the carotid artery sits kind of right in the sphenoid, and it's dehiscent in about 20% of the cases. And that's a really bad day if you don't know it's there and you accidentally hit it. And we can use it for characterizing tumors. And so you can use it to help characterize kind of the extent of the tumor relative to the sinus disease. And with that being said, often as a surgeon, I would actually prefer an MRI if you were going to get a CT scan, and I would probably do both if it was kind of one of these complex cases, not necessarily for routine CF imaging. I get an MRI to know exactly where blood vessels are, an MRI to know exactly where the brain is, the dura is, and the CSF spaces, and how that's very distinct from the bony confines of that the CT scan shows. And as an example of this is a CT scan here. This was one of the many children I saw this winter with I don't want to steal the punchline. So here we're looking at the side of the head, but you see ethmoid disease here. This is all gray. Gray is bad in my world. And then if we add contrast to the scan, all of a sudden you can see that the dura is pushed back here, and so there's an intracranial abscess here. You see some additional enhancement here. And then And then finally, if you get a CT scan, you can really clearly see where this dura is and kind of that there's a line here with the dura, but you kind of lose the bony skull base, which is a nice landmark to know exactly where it is intraoperatively. And so CT with contrast, great for abscess localization, good bone visualization, but an MRI is kind of definitely going to be superior for kind of soft tissue. So one of the questions that lots of pulmonologists at UNC ask me about is, what kind of CT scan do I need to get? And so generally the standard of care, if you're going to do endoscopic sinus surgery, which is just sinus surgery, is CT navigated sinus surgery to help kind of locate things. I think that's probably more important in the CF individuals because of kind of the hypoplastic sinuses, which we'll get to in a minute. But the difference is basically how thin the slices are that we're saving in the PACS server or that we're actually saving the data for. A normal brain scan can be up to 3 to 5 millimeters thick, and so every click of your mouse as you're going through it is 3 to 5 millimeters, depending on the exact protocols. Whereas a sinus scan for image guidance, they're usually either 0.5 or 0.625 millimeters, and so you're capturing a lot more data. That doesn't mean that the child or patient is getting exposed to more radiation. It means you're saving more of the data from the scan that was acquired. And it's really a hard drive issue of not getting that information, not a radiation issue, which was a surprise to me when I found that out. So this is a normal CT scan here from somebody who's giving a talk right now. If I can figure out. There we go. So the first sinus, so in general, when we're looking at CT scans as a surgeon, I always look at the coronals. So you're looking face on at the individual. This is the bony forehead, and you can see here a right frontal sinus, a left frontal sinus. Coming down, you'll see the septum in the middle, and the septum here looks pretty straight up and down. And I often tell my patients, this is an A+ sinus. You have white bone, black air, and no gray in between, and so that's as good as things can look. As we go back a little further, we'll go back to the cheek sinuses or the maxillary sinuses here. And so this is oh, you guys can't see the pointer. This is the right cheekbone over here, left cheekbone over here, upper teeth here, roof of your mouth shown here. And here you can start to see the septum bowing over to the left, but this cheek sinus is, again, it's an A+ sinus. You have white bone, black air, no gray inside. This one looks a little asymmetric here, but that's just the frame we caught it at. The ethmoid sinuses, or the sinuses between your eyeballs, tend to have more individual sinus cells. And so you can see these thin gray lines, thin white bones, and that's kind of the normal architecture that we expect to see in that region. As we go all the way back into the head, we'll get to the sphenoid sinus. Oh, missed it. So we got to the sphenoid sinus back here, and kind of this is the carotid artery sits right here, the optic nerve sits right here, and so those are the structures surrounding the sphenoid sinus, and kind of one of the reasons that we like to get that navigation. So that was kind of a quick summary of a normal CT scan in the coronal plane. So classic findings that we see in CTs in individuals with cystic fibrosis are, the first thing is hypoplastic sinuses. There'll be really small maxillary sinuses, almost absent sphenoid sinuses, and then the frontal sinus can be absent in about half of individuals with cystic fibrosis. The other things that are really common in individuals with cystic fibrosis are mucoceles and then bony remodeling. So here's an individual with cystic fibrosis CT scan. You can see the forehead sinus kind of in the top middle is fully gray. There's no black in here, and so this is kind of a F sinus, as I tell the patients. There's no air in it, and so that's not what you want. You'll appreciate that the left forehead sinus is present. The right forehead sinus is actually absent. It's aplastic or not there. And then as we go back in further, relative to that first scan, and this is an adult, you can really see how these cheek sinuses have extra thick bone here, and this sinus area, or this height here, is very, very small. So the height between the eye and the eye to the sinus is dramatically smaller. And this makes surgery technically difficult because it makes it easier to poke into the eyeball accidentally. You'll see opacification on this left ethmoid sinus here. And then this is kind of a classic finding in cystic fibrosis where you have a little kind of black sliver in here, but because there's no mucociliary clearance or minimal mucociliary clearance, you just see kind of these thick secretions, and this is actually kind of crusted, pseudomonas crust and some mucosal edema in that sinus. As we go back a little further in this scan, we get to the sphenoid, and here again, the bone becomes really thick because you don't develop pneumatization. And so this is actually the right sphenoid sinus over there, right sphenoid sinus over here, left sphenoid sinus over here, and dramatically smaller than they were on that previous scan. And so this is kind of a classic scan for an individual with cystic fibrosis. So mucoceles are the way I describe a mucocele to a patient is I say, if you think of your nose as being lined with all wallpaper, and all that wallpaper secretes mucus, if you block off a room completely, but the wallpaper keeps on dumping in mucus into the room, eventually it's going to expand and expand and expand. And it's either going to push through a window, push through the roof, or push through a door. And that's essentially what a mucocele is. It's an expansile object of mucus. It results from a blocked mucus drainage or a door that's not open. In non-cystic fibrosis individuals, it happens because of head trauma, and it can happen decades later. It can happen because of chronic rhinosinusitis, or it can sometimes just be bad luck. The concern about these are they can push towards the eye or towards the brain, and if they get acutely infected, they can swell and push more into those regions. There's some estimates in the literature that they are prevalent in up to 60% of patients with cystic fibrosis. And so this is another CT scan. The maxillary sinuses kind of look pretty healthy overall. And we'll come back to the front here. The sphenoid sinuses look good. But as we come up to the front, what you'll see here is there's a difference between the right side and the left side. You have a lot more gray over on the left side of the scan, which is this side here. And you can kind of imagine that this is kind of bony and rounded relative to this side over here. And so what this was, it was a mucocele from a previous surgery, or because of his cystic fibrosis. We can blame the surgeon or the disease, depending on your stance. But essentially, this got scarred off and just kept on expanding and expanding and gave him terrible frontal headaches. And so that's one of the other classic findings to look for on CT scans. So that rounded edge in that kind of frontal region. So bony remodeling is kind of the other classic finding in cystic fibrosis. So this is a 4-year-old individual, pre-tricapita. And so as we come up to the front again, what happens is basically the maxillary sinus gets completely filled with mucosa and infection, and it keeps on pushing the wall of the maxillary sinus over and over and over. And so this is actually the medial wall of the maxillary sinus. This is the maxillary sinus here. And it's actually pushed the inferior turbinate into the floor of the nose right here. And then this is the wall right here that should be over here. And so over this child's life, the whole contents of his maxillary sinus have pushed into his nose. And it was severe enough that his septum, which is the part that should be right in the middle, has also gotten pushed over. It's happened to a lesser degree on the left side over here. You can see kind of this is the native medial maxillary wall. It should go straight up to kind of the eye over here, but it's kind of bowing out and hitting the septum on the other side. And so this is kind of bony remodeling of the sinuses from chronic disease. This is an individual who, even with tricapita, if it made his sinuses clear up, would still have complete nasal obstruction because airflow can't move anywhere in this region, because that's actually his maxillary sinus that's expanded into his nose. So last part of the talk is kind of sinus imaging, when to get it. So as an ear, nose, and throat doctor who performs nasal endoscopy, and so patients come into my clinic, I put a camera in their nose, I look around. I recommend getting surgery for kind of my colleagues for surgical planning, because pretty much all individuals with cystic fibrosis are going to have some inflammation, and we don't necessarily need to see that. But if you're planning on surgery, it's very helpful for planning that in intraoperative use. And the other person I get a CT scan on is somebody who I can't visualize a sinus due to scarring, because I'm concerned there's a mucocele developing, which was kind of that case in the second individual with CF that we showed. For the non-ENT, I think that not getting baseline or surveillance sinus scans is reasonable. If you are going to get a CT scan, getting it after treatment, and whether that treatment is irrigations, antibiotics, nasal steroids, or something like that. And the practical reason for that is because if you don't do anything and you get a scan and it looks bad, you don't know what it would look like if you had done something. And then the other practical aspect of that is an insurance company might review it and say, you didn't actually treat anything, you showed they have sinus disease, but treat something and prove it again. And so it just kind of resets the clock for that patient. And then I think in cystic fibrosis, I see a lot of patients with worsening headaches. And I think oftentimes they get attributed to migraines or TMJ, and often they can be related to kind of small frontal mucoceles or blocked frontal sinuses that resolve very quickly with surgical treatment. And so with that, that is my kind of simple take on sinus imaging. There's not a ton of kind of advances in the research right now as far as CT, as far as imaging for sinus disease. I think in the future, AI is going to be important and might help us quantify disease severity. But as sinus disease is a disease of quality of life, really objective measures like CT scans haven't shown to correlate with how a patient perceives the severity of their disease at this point. So with that, I'll be happy to take any questions. Thank you guys very much for your time.
All right, so we do have a few here that came in through the app, so we can start with those while you guys are getting ready to ask them in person. The first question is, what do you use for contrast in this type of imaging, and how is it administered? Are there potentials for adverse effects?
Ooh, that's a great radiology question. So it's I believe it's an iodinated contrast. There's definitely concerns of anaphylaxis, itching with the contrast. And what was the other question? Adverse effects, what it is.
And what type of contrast?
It's given IV, intravenous.
Okay. Could you teach us about the osteomeatal complex, normal versus obstructive? It is often described in our sinus CT radiology reports.
Yeah, that is a fascinating question that radiologists love to use that term. So let me come back to me. And so basically the osteomeatal complex is the middle turbinate coming down next to the maxillary sinus. And so it's supposed to be the drainage pathway for the maxillary sinus, anterior ethmoid, and frontal. And the radiologists will generally call kind of any type of inflammation in that region blockage of the OMC, or osteomeatal complex. So this is the middle, you guys can't see that cursor. So middle turbinate here is the lollipop hanging down. Middle turbinate over here is on the other side. This little bony thing here is called the uncinate. That actually blocks the doorway to the maxillary sinus. And so mucus actually in the maxillary sinus has to travel up through this little hole here and then down. And so this whole region here is considered the osteomeatal complex. And so it would be grayness over here or over here on this side. And so it's not a particular sinus, it's kind of a region, and it's fairly poorly defined anatomically as to exactly what it is, but that's the general gestalt, where the maxillary sinus drains by the middle turbinate.
Any questions in the audience so far? I think we've had a few others. All right. I wanted to ask you if you can opine about incidentally found findings. So someone gets a head CT because they went to the ER, right? So they got a head CT.
I see a lot of these.
And is there actually a correlation with clinically significant disease if we find it incidentally and the patient's not reporting any sort of symptoms?
So I have a rhinology practice, and so I see lots of these. The most common one is a maxillary retention cyst.
Oh, yeah.
And I see them from dentists, I see them from EDs. And basically in around 20% of humans, you'll have a gray opacification down here kind of above the tooth area. And it's called a maxillary retention cyst. I'd tell people we don't need to do anything about it unless it's causing symptoms. And in general, if you have opacification down here in an individual with mucociliary clearance, it doesn't matter at all. Because if you have a lump here that's kind of a little water balloon of mucus trapped here, it really doesn't matter because all the drainage happens up here. And so your nose is going to function normally, and it'll probably go away if we follow it with time. And so it's really not important. The other incidental finding is a fungal ball, or you'll see this whole maxillary sinus is completely filled with stuff. I cut that out of this talk because we don't necessarily have enough time, but that probably clinically needs something, because if you ask that patient, they're probably having lots of drainage. And when you look in the nose, there'll be pus coming out of that side. And so fungal balls, I think, need treatment usually. That treatment is surgery, not antifungals. Mucus retention cysts, unless they're completely occupying a full sinus, don't need to be worried about.
Any other questions for Dr. Hipple? All right, thanks.
Thank you, guys.
All right, it is my pleasure to reintroduce Dr. Michael Monarchowitz, my co-chair of this symposium. He's a professor of pediatric gastroenterology and the Associate Dean for Health Affairs at the Children's Hospital of Colorado. He completed his MD at the University of Vermont, residency and fellowship training in hepatology and transplant hepatology at the University of Colorado. He's been repeatedly named a top doc in Denver and was a recipient of the Distinguished Service Award from the North American Society for Pediatric Gastroenterology, Hepatology, and Nutrition. He's a prolific author, involved in numerous studies of CF liver disease, and led the widely cited PUSH study through the CF Liver Disease Network. Dr. Monarchowitz will discuss the topic of advances in imaging for liver and pancreas in CF.
All right, let me get the pointer. Perfect. All right, thank you very much. These are my disclosures. The main one is I'm not a radiologist, but I do imaging research, and I heard radiology groups. This is what we're going to focus on today. I'm not going to cover every imaging modality. Some of this will be clinically appropriate, some of it will be really research-based. These are my educational objectives. So I'm going to start with abdominal ultrasound of the liver. So abdominal ultrasound really provides structural-based imaging of the liver and the surrounding organs. That you can add on techniques. You can assess blood flow. You can either put color on, which just tells you which direction blood flow is going, or you can look at the velocity with Doppler. There are several large studies in CF, most of them out of our group, I guess, and it is readily available. The caveat I would say, and I will show you data to back this up, is that there is significant inter-observer variability. And if we think about this as an outcome measure, that's a big issue. So if we look at it for a predictive measure, we led a prospective study called PUSH that tried to look at whether ultrasound could identify individuals before they developed advanced liver disease who were at high risk for developing advanced liver disease. So this is the often quoted PUSH study. For this study, we ended up screening 740 children aged 3 to 12 who were pancreatic insufficient by very strict criteria. They had to have fecal elastase or 2 severe mutations. All of these individuals were screened with abdominal ultrasound, and we had 11 centers and we had 11 study radiologists who underwent 2 rounds of specialized training. We actually studied this also. We found that the first round, with limited number of images, really did not yield good reliability in their readings. So these are specially trained radiologists beyond their usual training for research imaging. And every individual was assigned a grade based on what's commonly referred to as the Williams criteria, where you grade radiology images as normal, heterogeneous parenchyma, homogeneous, increased echogenicity in parenchyma, and nodularity. Those are the 4 criteria. And our hypothesis was that those individuals with a heterogeneous pattern would be at higher risk for the development of advanced liver disease based on a small study out of Montreal. Those children who were heterogeneous then were matched. Each individual had 2 controls selected from their center, matched for Pseudomonas, and matched for age. And then they were followed. This was an enormous undertaking. They were followed for 6 years, and it actually took us 8 years with our enrollment to do this. And the endpoint is the development of advanced liver disease as defined by imaging criteria, meaning a nodular liver. And what you can see are the final results of this study. So after 6 years, individuals who were heterogeneous at the start had a 9.5-fold increased risk for developing advanced liver disease. And you can see that it's 33% of those. I'll give you a little insight into the manuscript that's about to come out. If you look at a Kaplan-Meier curve, it's about 50% by 8 years that will develop nodular liver. Compared to the individuals with normal, where only 3% develop this. So it is, with a research ultrasound, able to identify a very high-risk group of individuals, children, before they develop advanced liver disease. So before you go out and you have your individual radiologist do this read, let me give you an unfortunate note of caution. So as we look through this data, the largest degree of variability in our study radiologist agreement was heterogeneous. So shown in the next line are the percent of individuals based on their grade and how many of those individuals had either 3 or 4 of the radiologists, and 4 radiologists read every study, agree. So 3 out of 4 or 4 out of 4 agreement. For normal and nodularity, it was quite good. It was about 80 to 90%. For heterogeneous, it was less than 50%. So that's the first thing you tell. And what I can tell you is there's actually a spectrum of disease there. This is an area where I think AI could help us and really drive this possibility. But we then asked the question, okay, let's just use the individual grade by the site radiologist. So when a child had an ultrasound, their site study radiologist read it, and then 3 others randomly selected. So let's just take that individual at the site, just like it would be if they were getting their routine ultrasound. How good were they? Well, not as good as you might want. So only 73% of the heterogeneous individuals would have been identified if we just used the local site radiologist read. Now, what I can tell you is if they were read as heterogeneous, they still had a 5-fold increased risk for development of advanced liver disease. So if identified as heterogeneous, it does identify a high-risk individual using our research-trained radiologists. But unless you use consensus grading, you miss up to 1/3 of individuals. So I don't think this is useful as in its current state for research. So the next question is it really sensitive for early disease? Well, the first problem I have in liver disease, and those who've heard me talk about it before, is we don't really have a gold standard for liver disease. But given that, I can still say with relative confidence, I believe, that the sensitivity is low for early liver disease and involvement. And if you think about that with a radiology imaging technique, that makes sense, right? However, its specificity for advanced liver disease is very good. So if you take one thing out of this, it's really that nodularity specificity is quite good for advanced liver disease. Are there things that we can do to add on? Well, there are a couple of things you can do. You can add a Doppler study, and that may identify advancing portal hypertension, or there are some new techniques. So I am going to tell you about a new technique in ultrasound, and that's microbubble ultrasound contrast. There's commercially available contrast agent with microbubbles that are embedded in it, and you can do real-time contrast studies. So, they want to compete with their CT and their MRI people, so they developed the contrast agent. It's not requiring radioactivity. And it has been shown in adults with cirrhosis to predict outcome. So shown here in the upper right-hand corner, the higher the percentage of hepatic vein transit time, the faster the time, the worse the portal hypertension. So normals have a relatively slow hepatic vein transit time, but as individuals get worsening liver disease, it declines. So this may be a predictive tool for complications and also a cut point to identify advanced liver disease. Let's move on to MRI. As to the ability of MRI in liver to predict advanced liver disease, the answer is it's unknown. It's not been studied. And you can imagine the reasons why. If you saw how many individuals we had to enroll in this study, I think it's going to be hard for me to even convince the CF Foundation to fund an MRI research study where we screen with almost 1,000. However, it probably has enhanced sensitivity for early disease. It's really good for hepatic fat content by a variety of techniques and has been studied in CF. So shown here is a graph from a paper by Dr. Cutney in Cleveland, where they looked at a very rapid sequence MRI in individuals with CF and those who had received no modulator therapy, and on the right in the orange showing high fat content in the liver, and those who had received modulator therapy showing lower fat content. So this is evolving. There have only been 2 small MRI studies to date in CF. There's also data that short T1-weighted MRI sequences, less than 5 to 10 minutes, can give you information about advanced liver disease. They can certainly tell you about the periportal tract, and periportal fat. This is an example from the second study with a short sequence T1 weighted, and this one actually happens to have some contrast in it, showing periportal tracking that is an early sign of fibrosis in liver disease. Again, I think this is going to be a little bit in the eye of the beholder. So again, I think quantifiable absolute measures, things that you saw in the CT imaging are going to be appropriate for this. Its specificity for advanced liver disease is really quite good and probably better with contrast enhanced. Well, let's move on to using ultrasound techniques to measure something else. What about stiffness of the tissue? So elastography measures the speed of transmission of either low-frequency waves or ultrasound waves through a tissue. The stiffer the tissue, the faster there is transmission through the tissue. It determines liver stiffness. Now, I'm going to put a caveat here. Liver stiffness, if I have right-sided heart failure and my IVC pressure is high, my liver gets congested, my liver is stiffer. If I eat and portal vein blood flow goes in, and particularly if I eat downstairs of Philly cheesesteak, I'm going to have a much stiffer liver because I get that. So there are other factors that contribute to this. It is, however, and fasting or not, it gives you values. It's correlated with hepatic fibrosis in lots of liver diseases, but it's not very good at separating out early grades of fibrosis. It's really good at advanced liver disease and normal. However, I'm not sure in CF that we need to correlate it with fibrosis. There's a recent study that just came out last week from the transplant group in Baylor, where they looked at elastography paired with liver biopsies, and this was in post-transplant individuals. But they found a particular cutoff for elastography actually predicted adverse outcome in their transplant patients. It did not correlate with fibrosis, but the value itself correlated. So it may not be important that this relates to fibrosis. It may be that we should ignore that, and it's a number, and longer-term studies will tell us whether it relates to this. So we can do it with either ultrasound or MRI. I'm not going to go too much into the techniques with that. I'm going to show you a little bit of data. Most of it's from our group, but we were not the first group to do this. The first group actually was in Boston about 15 years ago in CF. So elastography. On the left-hand side, you can see liver stiffness measurements for those who are nodular, and you can see that they are significantly higher than all the other individuals who had other ultrasound findings. This has been reproduced in lots of different studies. The advantage of the technique we used, which is vibration-controlled transient elastography, if you can get a qualitative assessment of hepatic fat. And so those individuals who had a homogeneous increased echogenicity on their ultrasound, which is felt to be fat, liver, had a much higher percentage of steatosis. So these are the type of data that you can get from this study. What about MR? So we've already put the kid in the MR for their xenon MRI or whatever their MRI is. And we can actually attach a paddle on top of the abdomen, and it just taps the abdomen, and you can get a very rapid sequence with 3 cuts through the liver and give you a whole liver elastography. And this we also performed as a pilot study in the PUSH group with Alex Tobin at Cincinnati Children's. And you can see here on the right-hand side, individuals with a nodular liver had a much higher liver stiffness by MR. So there are a variety of techniques. I'm really encouraged by work that just came out of the French group, and this came from Dominique Debray's group at Bichat. And it's a busy slide, but she compared vibration-controlled transient elastography, for those who know brand names, this is FibroScan, shear wave elastography, which is done when an ultrasound is done, and MR elastography. And she looked basically at the same groups that we looked at and found the same thing. But it's nice, all of these methods show that you can identify advanced liver disease. They also show it's really hard to tell between normal and mild liver disease. But if you looked at those who had severe outcomes, you could see that there were significant differences. So again, that value may be important more than does it correlate with it. But really, it doesn't matter which one you use. However you get elastography, it performs. So these are the key liver takeaways, and some of these we didn't talk about, but are from the Imaging Outcomes Workshop from the CF Foundation. I'm not going to read them to you. They'll be available. Let's quickly move to pancreas. So in pancreas, I think the key questions are, does it correlate with pancreatic function? Can it help us with chronic pancreatitis in people with CF? And as they get older, what's going to be the role for cancer screening? Because now we're going to have an older cohort with chronic pancreatitis, and we know it's a risk factor for pancreatic cancer. Ultrasound, really, I'm going to throw off the books. It misses parts of the pancreas. It's not a very good test. And CT has been basically replaced by MRI. Endoscopic approaches are really therapeutic now and not diagnostic, so I'm not going to touch on those. There is an evolving role for endoscopic ultrasound that might find a role in cancer screening because you can do directed biopsies underneath that. So we're going to focus on MRI. So standard MRI with T1 and T2 weighted techniques can really tell us about atrophy. They can show decreased signal, but unfortunately, those do not correlate with pancreatic function per se. Contrast-enhanced MRI can really show us about inflammation and fibrosis, but so can just a single T1 weighted MRI. An evolving technique, which is an MRCP with and without secretin, has been correlated with pancreatic function, particularly bicarbonate flow in the pancreas. So this is a technique that can do this. The challenge with this is it's a very long MRI, and secretin has been somewhat difficult to access. And then the future, I think, is diffusion-weighted imaging, which is going to tell us much more about pancreatic fibrosis and fat. So these are standard MRI techniques where you use fat-suppressed T1 and T2 imaging, and basically you get decreased signal compared to the normal pancreas if you have inflammation and fibrosis. The nice thing is we can see the ducts on the T2, and there are some objective outcomes we can measure, and that's what we need. You can look at pancreatic size, that's the major one, and ductal diameter, and you can look at ductal flow if you do that. So I talked a little bit about secretin-stimulated MRCP, and that really can show us ductal size changes and timing of duodenal filling. Both of those are there. My take on reviewing this is that it really doesn't add more information in most cases. Elastase is probably a lot cheaper to assess pancreatic function, except if we believe therapies are going to impact bicarbonate flow and may not improve acinar function. So that could be appropriate. I'm going to show you an example of a diffusion-weighted MRI of the pancreas, and this looks at random motion of water to determine diffusion coefficients, and it becomes less restricted in fluid-rich tissue and more restricted in fibrosis. Think of it as water as an elastography. That's the way I do. It's very sensitive to early changes and might be very sensitive to early improvement with that. It's never been studied in CF. This is an example of an MRI diffusion-weighted imaging, and the pancreas is actually right here, and the red is really much more fibrosis in that space. So in summary, you can see a variety of these techniques and what they can tell you about and all of the irregularities. But in summary, MRI is really the technique of choice that I see going down the future for pancreatic outcome research. So what about challenges? So breath holding can make the MRI very challenging. There's only been one prospective single-center study in CF, and it really needs further study. That's my take home for that. And then I'm going to leave you with something that just came out at this meeting. There had been a prior paper about using a very complicated MRI protocol to look at GI transit. So this came out of England. For this protocol, subjects are MPO. They have a test meal that's a standardized test meal, and then they get every 30-minute MRI scans for 3 hours, and then hourly on the hour scans. So it's 6 hours, so it's something like almost 10 MRI scans, each with 15 minutes. They can measure distinct outcomes: intestinal transit time, fecal to oral, oral to cecal time, small bowel water content, and volumes of organs. If you looked at poster 233, which I think is probably down by now, they did this before and after ETI therapy, and interestingly, they found no change in transit time and a little bit of an increase in small bowel water. So even with really sensitive techniques, I think that links to what we're hearing from patients in that they don't get dramatically better on ETI therapy in their GI symptoms, at least early on. So the key takeaways here are we can easily assess structure with MRI. Function, we still have a ways to go. I didn't talk about it, but there is some data looking at insulin secretion capacity in response to a glucose meal related to perfusion of the pancreas. With that, I'm going to thank all of the CFLD network centers who are outlined here, and thank you very much. No questions.
You don't get away that easily. All right. We did have one question come in so far. Why do you need breath holds when doing MR imaging of the pancreas?
My understanding, now remember, I'm not a radiologist, but my understanding from my friends is, it's a relatively small organ hidden right below the diaphragm, and there's a tremendous amount of motion with that. However, the breath hold with the new techniques is relatively short. I think you can get away with about 10 to 15 second breath hold now for it. And it's relatively quick cuts. I think the other advantage is if we think about if MRI becomes the way we're going to characterize the lung, getting relatively below the diaphragm with 3 to 5 cuts may actually be very helpful at characterization. So I was going to label it as, remember the plenary thing about multiple shots on goal? This is a multiple shots on goal imaging technique.
You briefly mentioned screening for pancreatic biliary cancers and CF post-solid organ transplant or not. Any opinion on the timing of this?
Yeah. So my disclosure is I'm a pediatric gastroenterologist, even though I did do pancreas for a long time. I think we don't know the answer to that question, but there are emerging reports of individuals in their 30s, and I think the real challenge is how do we screen them, right? Because their pancreas looks abnormal on MRI no matter what. They're going to get nodularity in other areas. So I think that we need a combination of biomarkers and really some prospective studies to answer that question. It's not an issue that's unique to CF. We have the same problem in chronic pancreatitis patients where we're not very good at screening and we don't have good ways to do this.
Any other questions from the audience?
I seem a bit deficient in my use of the app. So you mentioned AI algorithms for the future, and you have consensus reads basically for all of these liver ultrasounds. This is a perfect data set to actually do the AI. Is that already underway?
The AI is not underway. JP's getting up to leave, but I'm going to say it anyways. We submitted a grant to the CFF for this, and it wasn't funded the first time around, but I think we now actually have, so I'm going to plug this for my radiology colleagues. All of these data are actually now in the NIH data repository. So I think we have them in a form that can be done. The one challenge with AI, and we talked about this before, but the one challenge with AI and ultrasound is pixelated data. So it's a little bit, it's not like MRI or CT, but I think it's still doable with the current technology that's out there. And we have almost 2,000 ultrasound images, at which then you do the math in all of the cuts that we have. I think it's doable, and I think we could then apply it to this that could be of use to clinical centers and clinical reality. There's the plug, JP.
Mike, acknowledging I'm a pediatric endocrinologist, you're a pediatric hepatologist. This question is related to the recognition that there's some diabetes that's identified before the onset of pancreatic cancer. I suspect you don't know the answer to this, but I think it'd be worthwhile to think about, are we seeing an increase in diabetes before the onset of pancreatic cancer in that subset for whom that happens?
Yeah. So I think another way, Andy, to think about that is the presence of diabetes an additional risk factor that might identify a subgroup for screening?
I have one additional question for you or for anyone in the audience. I'm wondering if there's been any increase in reports or anyone concerned about the increased finding of pancreatic cysts post-Trikafta or pancreatic cystosis, because I personally have had about 3 patients, and it seems like, and it's something I've not seen before.
Yeah, so I'll tell you, I'm probably not surprised that that's happening, because if you look histologically at resected pancreas, they have very fibrotic obstructive areas, but behind those, they still have intact endothelial cells and acinar cells. So I think what you're seeing, which we've actually also seen in the biliary tree, is increased fluid secretion in the face of an obstruction. So it's the pancreatic mucocele, if you wish. But we also see this in the biliary tract, where immediately after therapy, we see a higher prevalence of obstructive biliary disease, because what's happening is they're moving stones that could not move before, and you're seeing them obstruct, and then they generally pass, but I think it's the same phenomena.
Interesting.
All right, we should move on.
Yeah.
All right. Batting cleanup. And hoping that the Phillies win tonight. I'd like to introduce Dr. Babette Zemmel. She's professor of pediatrics at the University of Pennsylvania Perelman School of Medicine. She is also in the Division of Gastroenterology, Hepatology, and Nutrition. She's an associate program director for the Center of Human Phenomic Science. I have no idea what that is, but we're going to find out. And she directs the nutrition core and the bionutrition unit at Children's Hospital. She holds several R01s around her interest in bone fragility and obesity in children. And for that reason, we've asked her to talk about bone imaging. Thank you. Have you done any of these?
No.
Okay. I'm going to set you up.
How do I control that? That's the pointer.
Here's the pointer. It's a laser.
Okay.
And we'll start, and then you can use the arrows now.
Okay. Well, thank you all for hanging in there, and thank you to the organizers for inviting me to come and talk to you. And I have nothing to disclose. I'm going to do a brief overview of the issues surrounding bone disease and CF and the recommendations for clinical assessment, and then give you also a quick overview of the research methods that are used for bone imaging, with specific focus on peripheral quantitative CT and high-resolution PQCT. So bone disease, or I should say low bone density, is reported to occur in 20 to 38% of children and adults with CF. There are a number of risk factors. Mostly, the worse off you are, the more likely you are to have bone disease. It does correlate with severity of lung disease, poor nutritional status, delayed puberty. It declines with age, as it does in the general population, but more rapidly in CF. It's also associated with prolonged glucocorticoid use and CF-related diabetes. So the recommendations for screening really haven't changed in quite a while. They were published in 2005. And the recommendations are to obtain an image using dual X-ray absorptiometry, or DEXA, on all adults and children over 8 years of age if they have a low ideal body weight, they have FEV1 less than 50% predicted, have had long courses of glucocorticoids, delayed puberty, or a history of fracture. It's also recommended that when doing a clinical DEXA scan, you get a value, you get a bone mineral density number, but you can't really interpret that number without comparing it to a reference. And in doing that comparison, we use Z-scores for children less than 18 years of age. We use T and Z scores between ages 18 and 30 because they're pretty much equivalent. But for people older than older than 30, we use the T-score. And I'm going to come back and explain what the difference is between the Z-scores and T-scores and how they're calculated. So this just shows you a child getting a DEXA scan at my center, and these are the standard imaging sites. We do the whole body, a lumbar spine scan, proximal femur or total hip scan, and the radius. There's also a lateral distal femur scan that's done in certain specialized centers for very specific reasons. The great thing about DEXA is that the radiation exposure is really low. You can see that for these individual scans, the values are less than 5 microsieverts. So if you have to do multiple scans or multiple sites, it's still very low compared to a round-trip transcontinental airplane flight in terms of the effective dose. One of the limitations of DEXA is that it's not really a volumetric density. In physics, we think of density as mass per unit volume, and in this square that is sort of symbolizing a vertebra, if we were to measure the density, it would be in grams per centimeter cubed. But DEXA is a two-dimensional imaging technique, so you can see that it takes the projection of this three-dimensional spine, and it's really a two-dimensional image, so it measures in grams per centimeter squared. So it's not a true density, and one of the consequences of this is that smaller bones appear to be less dense, especially if they're not as thick, which tends to go with overall size. So we'll come back to that. For children, we need to compare a bone density result to reference ranges, and these are examples of lumbar spine reference ranges that came out of a multi-center study that I participated in. And we use these to calculate the Z-score. So the Z-score is age and sex specific. So for a given age, for example, for males, there's a distribution of bone density values, and it compares that distribution and computes a z-score where a z-score or standard deviation score of 0 is equivalent to the 50th percentile, and plus or minus 2 standard deviations is considered the normal range in children, and below minus 2 is considered low bone density. The recommended scan sites for children are the whole body and lumbar spine. And these recommendations come from the International Society of Clinical Densitometry, which you can see down here. Sorry. Okay, I need to freshen my voice a little. But under certain conditions, you might want to do a different site. The proximal femur, the forearm, or the lateral distal femur are recommended for children when it's not safe to position them for a whole body or a spine scan, and that usually occurs when a child has contractures. If they have low or no weight bearing for some reason, so you want to capture some other sites of the body, or if they have medical or other artifacts that might interfere with the scan, because that'll affect the bone density results. And of course, with older teenagers, it's nice to get a hip scan so that as they transition into adulthood, you can continue to follow them, since the hip scan is the recommended site in adults. Another potential measurement is to do either an intervertebral assessment that can be done on some DEXA machines, or a lateral spine radiograph for identification of vertebral crush fractures, because that fits into the definition of osteoporosis in children. For adults, we don't use a Z-score, we use a T-score. The lumbar spine and the proximal femur are the recommended sites for measurement. A Z-score is a standard deviation score compared to age and sex, as you can see over here, and a T-score is a standard deviation score relative to peak bone mass. So for example, for this, 58-year-old or so who is down here on this red spot, you can see that because bone density declines with age compared to their peers, their Z-score compared to peers is minus 0.5. But compared to a healthy adult over here, their T-score is minus 2. And this graph over here shows you the World Health Organization classification scheme for osteoporosis, where osteopenia, or low bone density, is defined as -1 to -2.5 standard deviations, and osteoporosis is defined as having a DEXA bone density that's more than -2.5 standard deviations below the young adult mean. So I'm going to transition now and tell you about research methods for bone imaging. And mostly they are dependent on quantitative computed tomography. And as I mentioned before, DEXA is a 2-dimensional image, whereas QCT is a 3-dimensional image. So it's going to give us measurements in milligrams per centimeter cubed. It also has the advantage of being able to separately measure cortical and trabecular bone. And this is really important for understanding the nature of bone deficits. Also, by separately measuring them, we can get measures of bone geometry, such as the endosteal or periosteal circumference, and I will show you some images of what that looks like. And also from those measures, it derives measures of bone strength that are highly correlated with fracture in experimental models. So they've measured these in cadaver bones and put them under certain kinds of experimental stress conditions, and they know that these measurements correlate highly with fracture in cadaver bones. We can measure bone density and these other measures in whole body QCT scanners. This has the advantage of being very fast. It can measure both peripheral sites, such as the arm or the leg, or axial sites, like the spine or proximal femur. It's very feasible in children who have difficulty being positioned on a DEXA table or who have difficulty holding still, because the scans are very rapid. And also scanners are very widely available. The problem is that they're very heavily used for varied clinical diagnoses, so it can be difficult to get time on a whole body CT scanner. There are some concerns about radiation exposure, because it is much higher exposure than either the peripheral CT devices or a DEXA. But most importantly, the limitation is that the QCT analysis software is not widely available. There's one that I'm aware of that does that's commercially available for the spine. I think there's another one that is now trying to gain some traction in being able to do finite element analysis on CT scans, but you also need local expertise in order to run that software and interpret it, and the reference ranges are very limited, both for adults, and certainly the pediatric reference ranges are very limited. The peripheral quantitative CTs have had some success over the past, I think they've been around for about 20 years or so. These are tabletop devices, so they have a very small foot stamp in terms of the amount of time, space that they take. The scan times are extremely rapid. They're very precise and accurate, as is DEXA, I should say. I forgot to mention that. The radiation exposure is very low at peripheral sites because it's only marrow that's the tissue that's of concern. The effective dose is really low, and this is quite feasible for use in children down to the age of about 4 or 5. Some people have done it in younger children, but I'm a little suspicious of those. So at my center, this is where we do our peripheral CT measurements. You can do it in the radius or the tibia, and we like to do it in the tibia simply because it's a larger bone. So these are measurement sites that are relative to the length of the bone, and at the 3% site, you can see it's very rich in trabecular bones, so we get a measure of trabecular and total volumetric BMD. At the midshaft site, at the 38% site, we get cortical volumetric BMD. We also get measures of bone dimensions and strength. And then at the 66% site, we get a measure of muscle cross-sectional area, which is very helpful for interpreting the bone results because of the forces of muscle on bone during weight bearing to stimulate bone. So to give you an idea of what these cortical geometry measures are, this is the scan that I just showed you at the 38% site, and if you envision the tibia as being a circle, it measures the inner and outer radius of the bone, the periosteal circumference or the outer circumference of the bone, the endosteal or inner circumference of the bone, and from those measures it can infer cortical area and cortical thickness. But most importantly, those measures are used in some calculations that are commonly used in engineering to measure strength in shearing or polar moment of inertia, the section modulus, which is strength in bending, or a strain strength index, which is a combination of both the density and these structural strength measures to give us an idea of the overall strength of the bone. So to illustrate the use of a PQCT in children with CF, I'm going to tell you a little bit about a study that was done at my center. It was led by Rosara Bass and Andy Kelly. This was a longitudinal natural history study. There were 62 people with CF, 5 to 18 years of age, and 143 people in a healthy reference group that were imaged as part of another study, but we had longitudinal data on them. And we did both DEXA and PQCT assessments at baseline and 12 months later. The DEXA results were kind of unremarkable. Males with CF had a lower total body bone mineral content BMD score, which was adjusted for stature compared to the reference males, but their lumbar spine BMD Z-scores didn't differ, and there were no differences for females in any of those measures. Also, over 12 months, the change in bone density was within the expected range when you accounted for how much they grew, if they were still growing, and any changes in muscle and fat mass. So there were no differences between the CF and control groups. The females had slightly higher than expected values, so nothing particularly remarkable, but what's interesting is that we did see some differences based on the PQCT measures. So I know this is a little bit busy because it's different for males and females, but the open squares in either white or blue are the baseline measurements, and the hatched ones are at 12 months. Black and white are for the controls, and the blue values are for the CF group. So for both males and females, their section modulus, that measure of structural strength and bending, was low at baseline, and it stayed low. So we didn't see any improvement. Also, for both males and females, the periosteal circumference was low, and again, it stayed low. And also for males, cortical area and cortical thickness were lower. So what this means is that even though the DEXA was not it was picking up some modest differences. This is really showing us the nature of the differences between the group with CF and the controls and where those differences were. Interestingly, there were no differences in trabecular BMD, which is always thought to be the source of bone loss when you have inflammation and other sorts of problems. So more recently, high-resolution PQCT has been gaining traction. This is what it looks like. It's a much larger device, but it's also performing at a much, much higher resolution. So the PQCT that I previously showed you had a 2.3 millimeter slice thickness. The first generation of these high-resolution PQCT devices had an 82 micron thickness, and the newer version has a less than 58 micron slice thickness. And these are just some images. The one on the left is the distal tibia. The one on the right shows you the midshaft of the radius, where we get our cortical measures. The amount of information that we get out of the high-resolution PQCTs is almost overwhelming. So you can see this is a normal radius, this is an osteoporotic radius, and the difference, I think, is quite easy to see visually. And we can get from it not just trabecular density, but also the trabecular number and thickness and trabecular spacing, because sometimes there's a compensation between trabecular spacing and trabecular thickness. So some of these different measures help us to figure out what the nature of differences are when you do see similarity in trabecular density. It's not always the same structural strength. For the cortical bone, and you can see here it's outlined in red, we get the volumetric BMD of cortical bone, and we also get the outer dimensions, the periosteal circumference, and the cortical thickness. And the really cool thing about this is that we get a cortical porosity index. And I think if you look, you can see some of the pores in the cortical bone. And of course, this is something that's going to distinctly affect the structural strength of the cortical bone. And then lastly, from high-resolution PQCT built into the software, they have a finite element analysis, which looks at the entire structure of the bone and how it can bear the impact of a load and where the structural strength is. So it actually gives you a proportion of the strength that's in the trabecular versus cortical bone. And this estimated failure load, which is in newtons, is something that correlates really, really highly with experimental studies in cadavers. So to illustrate how this has been used in a study of people with CF, this is a really elegant study that Melissa Putman and colleagues published just last year on the effects of ivacaftor on bone density and microarchitecture in children and adults with CF. The sample included 26 subjects with CF who were planning to start or had already started within 3 months treatment on ivacaftor. There were 26 subjects with CF who were not on ivacaftor and 26 healthy volunteers. All were matched for age, race, gender, and Tanner stage, and it was quite a broad age range. It was ages 6 to 56. They did follow up at 12 and 24 months. And again, the results with DEXA were not particularly remarkable. They didn't find any differences in DEXA BMD or BMD-Z scores between those 3 groups at baseline. And they measured the spine, total hip, femoral neck, distal radius, and total body. So at all of those sites, they didn't find any differences, nor did they find any differences in the change over time. But the high-resolution PQCT results were really interesting. So these are among the many measures that you can get, and you can see that for cortical area, there was a very significant increase in the ivacaftor group, but virtually no change in the CF control or healthy volunteers. So there was also a decrease in trabecular area that corresponded to that increase in cortical area. So just looking at the image of the bone, the outer circumference of the bone didn't change. So in order to increase the cortical area, the trabecular area actually had to decrease because that cortical bone was thickening on the inner dimension. And then lastly, although it looks like there's a loss of failure load, the loss of failure in failure load was not significant, but it was significant for the other two groups. So remember, all of these things, unfortunately for most of us in this room, we are losing bone and we're losing bone strength. And so the CF group that was not treated and also the controls were losing in bone strength, but the ivacaftor group stayed right where they were. So just to summarize, DEXA is recommended for clinical use. It's a great screening tool. It's widely available. It has rapid scan times and very low radiation exposure. It's also very precise, and we have really excellent reference ranges for interpreting results. QCT imaging methods are mostly for research use. They have limited or no reference ranges, which make it difficult to interpret some of the results. So in doing research, we have to have control groups in order to assess how one group is changing relative to what would be expected in a reference group. But they do provide this very detailed information about cortical and trabecular bone density and microarchitecture. So we get a picture of bone strength that is far more detailed and informative than what we can get from DEXA alone. So I will leave at that, and thank you for your attention.
Thank you so much. Do you think there's promise in using MRI for assessing CF bone disease, measuring marrow composition as a potential marker or predictor of bone remodeling?
That's a great question, and I know that there are a number of groups. I don't know if anybody is doing it in CF, but I know that they've been looking at bone marrow in some other disease groups, and it is probably going to be a good indicator. I don't know if it's going to ever reach the point of being clinically useful. Okay.
Lovely talk. If we ever get our act together and get our patients' vitamin D levels up to where they need to be, and we keep them on modulators or something similar, do you see us getting to the chance where we could reverse some of this and make us look more like non-CF adults? Admittedly, at the age of 74, I know that my bone density isn't what I would like it to be.
I hope so. I mean, I think that there's still some things that we don't completely understand about CF bone disease and whether the receptors on bone cells are at all involved and in what way they're involved in CF bone disease, because there are all of these secondary disease factors that we know contribute. But I don't see why not. I mean, I wish I had a crystal ball and could read the future for you.
I'll ask you a quick question. I know you were talking about the quantitative CT and that there's fact that there's no normative values yet in which to compare to. Have there been any studies looking at if it's useful as a predictor for fracture risk?
Well, for studies that are using CT and finite element analysis, that's kind of used as a surrogate for fracture risk.
Okay.
So there just are not that many studies that have used whole body CT. Is that what you were asking me about, or any of the CT methods?
Actually, any of the CT methods.
Yeah, I actually don't think that, to my knowledge, there isn't a study that has looked at fracture prediction. The problem being that, at least in kids, because I'm at a pediatric center, typical children who don't have CF have a very high fracture rate, and it's usually due to accidental injury in sports. And so when you're comparing a group that may not be as engaged in those levels of physical activity, they often have a lower fracture rate than typical kids. So it's really difficult to find it. So we use these surrogates.
Interesting.
much about any of this, so this might be a very ignorant question. I was thinking about it with Trikafta, we've seen interesting changes in BMI and body composition, and I was just wondering about, when do you think it's time to revisit those guidelines about the frequency of DEXA scanning, and should body composition measures like maybe be included in whatever risk stratification algorithm that's designed?
I think we need a really big study on body composition to see what the changes are. Because if BMI is increasing, but it's an increase in fat mass and not an increase in lean mass, then yes, BMI is not going to be a good marker. So even if somebody's at 110% of ideal body weight or at the 75th percentile, then they may not be developing lean mass, which is needed to support healthy bones. The other thing is that with obesity, obese people have higher bone density, but they do have higher fracture risk. And part of it is simply mechanical because the force of a fall is greater when you're a heavier person. And part of it may also due to the inflammatory cascade that goes along with obesity. So, yeah. Yeah.
All right, well, thank you so much. Thank you to everyone, and have a safe trip home.